we have one last type of chemical messenger to discuss, and that is this category of what's called eicosanoid chemical messengers. So eicosanoid chemical messengers, let's start off first of all by saying that they are always formed from what's called arachidonic acid, which is a type of lipid. To really have an eicosanoid messenger, most of the time it needs to be derived from arachidonic acid, this lipid. Now, beyond that, what are eicosanoid messengers? They're really always paracrines. Okay? So if it's a paracrine, what does that mean about the chemical messenger? The cell releases it, it travels a very short distance through the interstitial fluid, and then binds to the target cell. So we can generalize with both of these things, really. Most of the time, eicosanoids are formed from arachidonic acid, which is a lipid. Most of the time, eicosanoids are paracrines. And what's their structure? Well, we know that they're formed from arachidonic acid, which is a lipid, which tells us that eicosanoids really have to be hydrophobic, right? And if they're hydrophobic, where must the receptor for eicosanoids be located? Well, it must be located inside of the target cell, right? Because the fact that eicosanoids are hydrophobic, right? They're nonpolar because they're formed from a lipid. They're made up of mostly hydrocarbons. That tells us that eicosanoids can rip right through the core of the plasma membrane and into the target cell. And then the receptor for the eicosanoids will actually be located inside of the cell itself, not on the plasma membrane. So this is one of the chemical messengers that I'm actually going to give you a relatively detailed example of. One of the most common classes of eicosanoid chemical messengers is what are called prostaglandins. Prostaglandins are a type of eicosanoid. And we're going to actually take a look at what prostaglandins may do inside of the human body. There are many, many things actually, but we're going to focus on one. And then we're actually going to tie it together clinically with some drugs actually that are used to try to combat issues that may be caused by the eicosanoid that is these prostaglandins. Here is a more detailed image of the actual creation of an eicosanoid that we call prostaglandin. So remember, we always have to start off with arachidonic acid. And then we can turn arachidonic acid into an eicosanoid. So you can see arachidonic acid being turned into the eicosanoid that we call prostaglandin. And one thing I want to point out right away is the enzyme that accomplishes this. The enzyme that will actually turn arachidonic acid into this eicosanoid prostaglandin is the COX enzyme, which is cyclooxygenase. Cyclooxygenase, this COX enzyme, is the enzyme that you need to actually make prostaglandin from arachidonic acid. So just keep that in the back of your mind for the next couple minutes, and it will quickly come back up in conversation. So just quickly, here's an image of a cell creating prostaglandin. Right? It's ultimately taking arachidonic acid, using this COX enzyme, and turning arachidonic acid into prostaglandin. And then what's prostaglandin doing? It's leaving the cell, traveling a very short distance, and targeting another cell. So again, that clearly tells us that prostaglandin, this eicosanoid, is a paracrine. Right? That's what paracrines do. And we can be certain also that the receptor for prostaglandin is actually going to be located inside of the target cell. So that's great. I think you can look at this image and get a fairly decent idea of what it's showing. But let's actually talk about, in real terms, what is actually being depicted here, because this is, in fact, a blood vessel that you're looking at. So this is an image of a blood vessel. And a blood vessel generally has 3 layers. It has an inner layer. I don't know what color to do that in, maybe red. It has an inner layer called the tunica intima. It has a middle layer. How about we do that in black? That's called the tunica media, and it has an outer layer, why don't I do that in yellow, which is called the tunica externa, sometimes adventitia, as is depicted in the image, but externa it's also called sometimes as well. Now, the question really is, what are these different layers made up of? And the answer is the tunica intima is made up of a whole bunch of what are called epithelial cells, squamous epithelial cells, simple squamous epithelium, also called in blood vessel terms the endothelium. These just small flat-shaped epithelial cells, a single layer that lines the inside of these blood vessels. And what we think these epithelial cells called endothelial cells. The epithelial cells that are specific to blood vessels are called endothelial cells, if that wasn't clear. And what we think that they can produce is prostaglandin, that eicosanoid. And then the question becomes, well, what does that eicosanoid prostaglandin do? And we think that let's do that in red, the endothelial cells, the epithelial cells that line the lumen of the blood vessel, we think when they produce prostaglandin that it moves into the tunica media, the middle layer of the blood vessel. And that tunica media is made up of smooth muscle. And the smooth muscle has two possibilities. It can either contract or it can relax. When the tunica media contracts, the lumen, the hollow opening in the center of the blood vessel, becomes more narrow. Right? Becomes more narrow, becomes smaller. Right? So that's a smaller path for blood to travel through. Now, when the tunica media, the smooth muscle in the middle layer of the blood vessel, relaxes, the opposite happens. The lumen becomes larger. The diameter increases. So one more time, when the tunica media, the smooth muscle of the tunica media, relaxes, the hollow opening in the center of the blood vessel called the lumen, right, it increases in size. The diameter increases, and now blood has more room to travel through. Right? We call this vasodilation. The internal opening of the blood vessel becomes larger. Here's a nice image of that, right? Here's a normal artery. You can see the three layers. Okay, what we're interested in really is this middle layer, the tunica media, which is made up of smooth muscle. If that smooth muscle contracts, look what happens to the hollow opening in the center, called the lumen. Right? If the muscle that makes up the tunica media contracts, then the lumen, the hollow opening in the center, becomes clearly more narrow. Now, if the muscle that makes up the tunica media, the smooth muscle, relaxes, now it's relaxed, what happens to the hollow opening in the center called the lumen? It increases in size. The diameter becomes larger. These are the two options that blood vessels have. They can either vasoconstrict, meaning that the tunica media smooth muscle contracts and the lumen, the hollow opening in the center, becomes more narrow, or they can vasodilate. And if they vasodilate, the muscle of the tunica media relaxes and the hollow opening in the center increases in size. The diameter becomes larger. And then you might say, well, how does all of this, again, relate to that eicosanoid that is prostaglandin? And I told you already, but let's kind of refocus where we were. This is the same image that you saw before, but now I can kind of refocus your attention and probably better explain what you're seeing here. These are the epithelial cells that make up the tunica intima. As I said, these epithelial cells are also sometimes called the endothelium. Right? These are the epithelial cells that line the lumen, the hollow opening of the blood vessel. And what do we think that they can produce? We think that they can produce prostaglandin. And then what does that prostaglandin do? Well, you know, I told you already, but again, hopefully now you have a little bit more context, it makes a little bit more sense. The prostaglandin can leave those epithelial cells, those endothelial cells, and it moves into what you're seeing now, which is the tunica media, right? That middle layer, and these are the smooth muscle cells that make up that middle layer. And what we think actually happens is that prostaglandin goes into the smooth muscle cells that make up the tunica media, and there are receptors inside of the smooth muscle cells, which makes sense, right? Because prostaglandin 1 is an eicosanoid, so it's a paracrine, right? It travels from the epithelial cells a very short distance and then gets to the target cell, which is the smooth muscle in the tunica media. And then the prostaglandin rips right through the core of the plasma membrane of the smooth muscle cell, because the prostaglandin is, it's nonpolar, hydrophobic, because it's formed from a lipid, which is arachidonic acid. So it rips right into the smooth muscle cell, binds to a receptor inside of the smooth muscle cell, and causes the smooth muscle cell to relax. So that was a very long-winded way of saying to you, kind of trying to tie all the terms together, which is what I was doing there. But what prostaglandin does is it's released by the cells of the tunica intima, the inner layer of the blood vessel. And then we think that the prostaglandin moves from the cells of the tunica intima into the cells of the tunica media, the smooth muscle cells, and causes them to relax. And what would that result in? Result in vasodilation. We think that prostaglandins cause vasodilation of blood vessels. How? By causing the smooth muscle cells of the tunica media, the middle layer of the blood vessels, to relax. And we know that's what causes vasodilation. It increases the diameter of the lumen, the hollow opening in the center. And what's the relevance of all of this? Well, what we think is, in most people, this is what causes headaches. Let me say it this way. We know that vasodilation of blood vessels in the brain causes headaches. There's really no doubt about that. The question more so is what's causing the vasodilation. If a bunch of blood vessels in your head vasodilate, that's when you'll have the experience of a headache. The kind of throbbing sensation you get in your head, that's actually, we believe, from vasodilated blood vessels. And no one fully understands headaches, by the way. So I'm just, so much of this is theory. But we know something is causing vasodilation of these vessels in the head. And one of the things that we think causes this vasodilation is, or are, these prostaglandins. This class of eicosanoid. It's doing it by causing, the smooth muscle of the tunica media of these blood vessels in your head to relax, and thus causing vasodilation. Now we know that prostaglandins also are probably involved definitely in inflammation and maybe pain signaling and all sorts of other things as well. So this conversation can go down 200 different paths. So we need to try and stay as focused as possible. So let's talk about a really common class of drugs and that are used to treat headaches, and in theory why they would cause headaches. And I think, to the surprise of a lot of people, you find this out about a lot of drugs if you really start studying physiology and pharmacology and pathophysiology. A lot of the drugs that we take, we don't really know how they work. We have an idea of what they do, but why that translates into the effect that they have, much of the time, we're just not entirely sure. We just know that they work. That's what you're about to see here. So let's say someone has a headache, or you have a headache. What do you go for? Probably something like ibuprofen, aspirin, Tylenol, one of those drugs. And there are some differences between those drugs. But what they all do is every single one of them goes after that COX enzyme, that cyclooxygenase enzyme. And they all inhibit it, every single one of them. There are different COX enzymes which create different prostaglandins, which leads into a whole different conversation that's outside of the realm of this class. But I can promise you, every single one of those drugs targets the COX enzyme. And it inhibits that COX enzyme. And somehow, the inhibition of that COX enzyme causes a lot of people's headaches to go away. Not everybody. They don't tend to work very well, for example, for like migraines, which is really not a headache. I mean, by definition, the head definitely aches, but there's something else going on with migraines that are probably causing that inflammation. And for whatever reason with migraines, this class of drug doesn't work quite as well. But for the vast majority of people that just get standard headaches, these COX inhibitors seem to work really well. So what is it about somebody with a headache taking a COX inhibitor, like Tylenol or aspirin, that causes their headache to go away? I think the answer should be pretty clear about what the drug is doing, if everything that we've been saying makes sense. Okay, so we're back to this image you've seen before. Here is the tunica intima, right, which is lined by those epithelial cells called endothelial cells. And what do they produce? They produce prostaglandin. Okay. Here is the tunica media, the middle layer of the blood vessels, where the smooth muscle cells are that can contract and relax. So if this person is having a headache, if you're having a headache, then perhaps these epithelial cells that line the tunica intima are overproducing prostaglandin. And what's the prostaglandin doing? It's a paracrine, so it's moving into the tunica media and into the smooth muscle cells, which line the tunica media and make up the tunica media and causing them to relax. And what's happening in this person's head or your head is you're getting lots of vasodilation. The blood vessels are overdilated. The lumen, the hollow opening in the center, is very wide. The diameter is large, and that, in theory, would be causing the headache. You could feel your head throbbing. All right, so then what do? You grab Tylenol or aspirin or whatever COX inhibitor you decide to grab, and you take it. And what's going to happen is that Tylenol, it's actually acetaminophen, is the technical term, is the actual drug. Better said, that's what's actually in Tylenol. Tylenol is just a company, right? It's a brand name. So what acetaminophen will do is you'll consume it, it'll enter into your bloodstream, and then it will start inhibiting these COX enzymes in your body. So acetaminophen will go into these epithelial cells and, in theory, start inhibiting the COX enzyme in the epithelial cells lining these blood vessels. Acetaminophen is oftentimes abbreviated APAP. So what APAP will do is, I'm showing you, APAP is inhibiting this COX enzyme. So if APAP, acetaminophen, inhibits the COX enzyme, what is this epithelial cell not going to produce anymore? Well, it's not going to produce any more prostaglandin, right? Because you need this cyclooxygenase enzyme to turn arachidonic acid into this eicosanoid that is prostaglandin. And if you take Tylenol, acetaminophen, it will knock out the COX enzyme, and it will knock out the epithelial cell's ability to actually make prostaglandin. If the epithelial cell isn't producing prostaglandin anymore, then what's going to happen to the smooth muscle cells in the tunica media? Well, the prostaglandin was causing these smooth muscle cells to relax. Right? Well, if there's not any more prostaglandin, because the person took Tylenol, acetaminophen, which knocked out the COX enzyme, which was what was enabling for the creation of prostaglandin. So now there's not prostaglandin anymore, right? Prostaglandin levels are reduced. Then nothing's going to tell these smooth muscle cells to relax anymore. And what are they going to do instead? They're going to contract. And if they contract, then what's going to happen to these blood vessels? They're going to vasoconstrict, and that, in theory, should eliminate the throbbing. It should eliminate the headache. So while the headache is going on, the blood vessels in the head look like this. They're vasodilated because of the fact that prostaglandin is causing the smooth muscle cells of the tunica media to relax, and thus the blood vessels are vasodilated and you're having a headache, right? Then what does the person do? The person takes Tylenol, acetaminophen, and acetaminophen goes into, how about we do that in, green. It goes into the epithelial cells that line the tunica intima, and it inhibits the COX enzyme inside of those epithelial cells, right? It would be over here too. Maybe I'm getting a little ahead of myself with the image on the left. So the acetaminophen goes into the cells of the tunica intima, knocks out the COX enzyme, and now the cells of the tunica intima, these epithelial cells, can no longer produce prostaglandin. And if they can't produce prostaglandin anymore, then nothing's going to tell the smooth muscle cells of the tunica media to relax, and those smooth muscle cells are going now to contract now because the prostaglandin is gone. And when the smooth muscle cells contract, what do we get? We get what's on the left over here. We get vasoconstriction, right? And the lumen, the hollow opening in the center, decreases in diameter, it becomes more narrow, and that then, in theory, eliminates the headache. This is the primary driving theory as to what Tylenol does, or COX inhibitors do, to eliminate headaches. Right? The APAP, acetaminophen, in this case, travels through the bloodstream, goes into the cells of the tunica intima, knocks out the COX enzyme, prevents them from producing prostaglandin, and without prostaglandin, now the smooth muscle cells in the tunica media contract rather than relax, which causes vasoconstriction over here, and thus the headache goes away. Just in case you forgot what we were doing, we were looking at this type of chemical messenger, which is called eicosanoid chemical messengers. And unlike the other chemical messengers, we tried to give some degree of, kind of a clinical correlation here. And I decided to do this intentionally with eicosanoid chemical messengers and not the others, because we're going to spend a lot of time throughout the semester actually talking a lot about those different chemical messengers and what they do in the body. And this one really not so much. We don't really get to talk much about eicosanoid chemical messengers in this course, which is why I wanted to do right now, give you some degree of an expanded explanation of what eicosanoid chemical messengers are, what they do, and real life instances inside of the body where, we can take drugs to try to manipulate them. Throughout the semester, we'll do that a lot with the other chemical messengers, other types of chemical messengers we've discussed in the last lecture, actually. But we'll do them we'll do that in future chapters, not this one. So now we have more or less finished this table of different types of chemical messengers. What class do they fall into? What's their chemical property? Where do we find receptors for each one of them? We've talked about all these in a decent amount of detail. And now we have a couple more things to say more broadly, really about all chemical messengers. So first of all, what's going to influence the magnitude of effect that a chemical messenger is going to have? The main thing that's going to influence how much of an effect a chemical messenger has is how many receptors is it actually bound to. So if you've got a cell, okay, here's a cell. This cell is going to have thousands, millions of receptors for a given chemical messenger located on it, not just one. Like we talked about amino acid-based chemical messengers, which are typically neurotransmitters, right? They're hydrophilic and thus have receptors located on the plasma membrane of target cells. So if this is a target cell for a neurotransmitter, an amino acid neurotransmitter, there is going to be thousands of receptors for it. Okay. And the number of receptors that the chemical messenger, in this case the neurotransmitter, is bound to is going to influence the magnitude of effect, how much of an effect the neurotransmitter has on this cell. What's going to influence how many of these neurotransmitters are actually bound to these receptors? And of course, it's the concentration of neurotransmitter that's actually in the interstitial fluid, at least in the case of these amino acid-based neurotransmitters. How many of them, concentration-wise, are actually located in the interstitial fluid around the target cell? And that's what this graph is showing you here. If you increase the concentration, right, the more that you increase the concentration, the more receptors that you will have bound to the neurotransmitter on the target cell. And thus, the greater effect that chemical messenger, in this case neurotransmitter, will be having. This is really true across the board. Right? The more of the chemical messenger, as you increase the concentration of the chemical messenger near the target cell, the more receptors that chemical messenger will be bound to on the target cell, and thus the greater effect that chemical messenger will have on the target cell. I think on the surface this is logical, right? The more epinephrine someone has in their bloodstream, you know, the greater the fight or flight response will be, the higher their heart rate will be. But why? Why, when there's more epinephrine in the bloodstream, is heart rate even higher? And the answer is because there's a higher concentration of epinephrine around the heart. And thus there's more epinephrine bound to more epinephrine receptors on the heart, as would be depicted in this image, right? If there's a higher concentration, let's say over here, of epinephrine around the heart, then there's going to be more epinephrine bound to more epinephrine receptors on the heart, and the magnitude of effect that epinephrine is having on the heart will be significantly greater. What that means is heart rate be much higher than if epinephrine concentrations were lower and there was less epinephrine bound to less epinephrine receptors, right? And the magnitude of effect would be less. So general rule, increase the concentration of chemical messengers around a target cell, more chemical messengers will be bound to more receptors, and you'll have a greater effect. The next thing is the affinity that the receptor has for the chemical messenger. Okay, so for example, on the heart, there are, as I've already said, epinephrine receptors. They're not called epinephrine receptors, they're called adrenergic adrenaline receptors. Okay. I'm drawing some for you. This is a heart cell, a cardiac muscle fiber on the heart, and it has adrenergic adrenaline receptors on it. Okay, so there's actually, you know, quote unquote, two different types of adrenaline. There's epinephrine and norepinephrine. So we'll say there's epi and norepi. Okay. These are actually two different chemical messengers, as you'll see later on in the semester in much more detail. Now, adrenergic receptors on cells, really all adrenergic receptors can bind both epinephrine and norepinephrine, but they have different affinities. Some adrenergic receptors bind epinephrine much better than they bind norepinephrine. And some adrenergic receptors are the opposite. They bind norepinephrine much better than they bind epinephrine. Another way of saying that is some adrenergic receptors have much higher affinities for epinephrine than norepinephrine. And some adrenergic receptors have much higher affinities. They bind norepinephrine better than epinephrine. And this is going to influence, ultimately, if we give an example, which I'm going to do in a second here, how much epinephrine or norepinephrine is bound to receptors on the heart, and thus what the magnitude of effect is going to be. Again, what I'm saying here is if a receptor has a higher or lower affinity for a given chemical messenger, then that will influence the number of chemical messengers that are bound to it, and thus the magnitude of effect that it has on the target cell. To provide an example of that, here's a cell. It has adrenergic receptors. These adrenergic receptors have a much higher affinity for, let's say, epinephrine compared to norepinephrine. Now do this. Here's the bloodstream. Let's say that there's two different circumstances here. Okay. There's a certain amount of norepi in the bloodstream right now. Let's say that concentration is right here. Okay. Now, these adrenergic receptors have a pretty low affinity for norepinephrine. They don't bind norepinephrine all that well. So at this concentration right here, there's not going to be that many adrenergic receptors that are actually going to bind norepinephrine, because these receptors don't have a very high affinity for norepinephrine. Now, some of them will still bind norepinephrine, but since the affinity is low, they won't be, not all of them will be binding norepinephrine, and there's other things that could be happening related to this as well that we don't need to get into right now. So what does that mean? Because these adrenergic receptors have a relatively low affinity for norepinephrine, the magnitude of effect on this target cell won't be all that high, right? Because again, these adrenergic receptors don't have a high affinity for norepinephrine, so not many of them are actually going to bind norepinephrine, and thus the effect on this cell won't be very high. We could say, well, heart rate won't go up that much, if you want to give an example of the heart. Now, let's reverse it. And we're going to say, we're going to put the exact same concentration now of epinephrine in the bloodstream. Okay? These receptors have a very high affinity for epinephrine. So this is the exact same concentration. We're going with the exact same concentration of the chemical messenger in the blood, but now it's epinephrine instead of norepinephrine. Exact same concentration. Since these adrenergic receptors have a very high affinity, meaning they bind epinephrine very well, at that exact same concentration, right? But we've just switched it. It was the same concentration of norepinephrine, and now we have the same exact concentration of epinephrine. There will be much more epinephrine bound to these adrenergic receptors, right? Because these receptors have a very high affinity for epinephrine. They bind epinephrine much more easily. So at the exact same concentration, look at this, you will have many, many more receptors that are actually binding epinephrine at the exact same concentration. And thus, the magnitude of effect that the chemical messenger, in this case epinephrine, has on the target cell will be much greater, right? Heart rate will go up much more significantly if we have epinephrine in the bloodstream rather than norepinephrine at the same concentrations. So this is something else that also will influence the magnitude of effect, right? The magnitude of effect that a chemical messenger has on a target cell is, one, going to be influenced by the concentration of the chemical messenger around the target cell. Right? We just went through that in the last example. If there's a higher concentration of the chemical messenger around the target cell, then more of the chemical messenger will be bound to the receptor, and the greater the magnitude of effect. The other thing that can influence the magnitude of effect is the affinity that the receptor has for the chemical messenger. If the receptor has a very high affinity for that chemical messenger, then more of the chemical messenger will be bound to more receptors and the magnitude of effect will be greater. If that receptor has a low affinity for the chemical messenger, then less of the chemical messenger will be bound to less receptors and the magnitude of effect will be lower. The next thing that can influence the magnitude of effect that a chemical messenger has on a cell is the number of receptors that a cell has for a chemical messenger. This should seem fairly obvious. Here's a cell. Let's say that it doesn't have very many chemical messenger receptors. It doesn't have very many receptors for a given chemical messenger. It doesn't have very many epinephrine receptors. Okay, I've shown you that this cell only has 4 epinephrine receptors. Then the magnitude of effect that epinephrine can have on this cell is relatively low because there's not actually many receptors for epinephrine located on the cell. Now, if there was a ton of epinephrine receptors located on the cell, then the magnitude of effect that epinephrine, the chemical messenger, could have on this cell is much greater. Okay, because epinephrine, the chemical messenger, could bind to many more receptors located on this cell and have a much greater effect, magnitude of effect, on the cell itself, the target cell. So this is something that is huge that you have to take into consideration, is how many receptors for a given chemical messenger does a cell have? The less receptors that a cell has for a given chemical messenger, the lesser magnitude of effect that chemical messenger will have on the cell. The more receptors that a cell has for a given chemical messenger, the greater the magnitude of effect that chemical messenger will have on that cell. I'm going to give you an example here of how the number of receptors for a chemical messenger can influence the magnitude of effect. Additionally, I'm going to show you what cells can do to change the number of receptors they have. This is called up and down regulation. All right, so what you're seeing here, we're going to get, in this class, we're going to get into neurons quite a bit. So you're going to see this process played out in pretty significant detail later on in the course. But we can go through enough information here, I think, that we can make basic sense of this. Okay, so this is a neuron. And what the neuron is releasing is a chemical messenger. The chemical messenger is traveling a very short distance, binding to another cell, the target cell, right? In this case, the target cell is another neuron, right? So these are 2 neurons communicating with each other. But thinking about the chemical messenger, since it's being released by a neuron, traveling a short distance and binding to the target cell, the chemical messenger must be a neurotransmitter. Okay? So this neuron is releasing neurotransmitters. And the neurotransmitter that it's releasing, in this case, is what's called serotonin. Maybe you've heard of that before. Okay? Some neurons in the brain, what they do is they release a chemical messenger, a neurotransmitter that's called serotonin. Serotonin is a chemical messenger. Okay? What serotonin does is it binds to serotonin receptors on other neurons in the brain. That's actually what's being depicted here. Serotonin is it's hydrophilic. It's charged. So the receptors for serotonin on other neurons have to, of course, be located on the plasma membrane, which is what's depicted there, right? The receptors couldn't be inside of the cell. Now, what does serotonin, this chemical messenger, right, this neurotransmitter, what does it do to other neurons? It causes other neurons in the brain to generate these things called action potentials, these electrical impulses. Okay? What's happening here is when serotonin is released by this neuron. Right? Serotonin is released by this neuron, you can see through exocytosis. And serotonin then binds to receptors on this neuron here. And when serotonin binds to the receptors on this neuron, it causes this neuron to generate an electrical impulse called an action potential. And when this particular neuron generates an action potential in your brain, because serotonin bound to it, bound to receptors located on it, we believe these particular neurons in a certain part of the brain that bind serotonin are what allow us to feel content. I'm not a psychologist, so I'm sure I'm not using the correct terms here because their emotions are very, very specific. But when this neuron right here, this neuron that binds serotonin, generates this electrical impulse called an action potential because serotonin is binding to it, that allows human beings to feel the sensation of, just feeling good, feeling content, feeling happy, satisfied with life, let's say. It's essential that these neurons that bind serotonin in different regions of the brain generate these electrical impulses, because if they didn't, then the person in theory wouldn't feel very good. They would feel what we term as depressed. If these neurons here that bind serotonin didn't generate these waves of electricity called action potentials, then these neurons in the brain aren't generating electrical impulses, and then we are not feeling the sensation of happiness, content, so forth and so on, and we would call that person depressed. By the way, these are theories that we apply medicine to. So, there's debate on all things related in science, but this is, our basic understanding of depression. So let's talk about this some more. So what we would say is this person is depressed because these neurons that bind serotonin aren't generating electrical impulses called action potentials. You need these neurons to generate these electrical impulses in order for the person to feel satisfied and happy. And they're not, for some reason. That would be the theory as to why the person is depressed. Okay, so these neurons aren't generating these electrical impulses. Why? And that is, you're starting to get into an area that we, just don't know that much about. What is it? We certainly can make some guesses, and I'm about to do that, but why won't these neurons generate these electrical impulses? Well, it could be a variety of things. Let's go through the simplest ones. Maybe there aren't enough serotonin receptors located on that neuron, right? Remember, that's one of the things that will influence the magnitude of effect. If there's not enough receptors located on this neuron, then not enough serotonin will bind to those receptors, and this neuron won't generate very many electrical impulses, and the person would feel depressed. So it could be a lack of serotonin receptors. Remember, the number of receptors has a big influence over the magnitude of effect that a chemical messenger has. Maybe for some reason, these receptors have a reduced affinity for serotonin. Right? They just don't bind serotonin very well. Maybe it's some genetic thing that causes this to happen. Well, you know that if receptors have a low affinity for a chemical messenger, they don't bind that chemical messenger, in this case serotonin, as well. Well, that could cause a reduction in the number of electrical impulses that this neuron generates, and thus the person would feel depressed. It could be that there's a lack of actual chemical messenger, serotonin, around this neuron, right? The concentration of the chemical messenger is too low. That could also be certainly a problem. Remember, if there's a lower concentration of a chemical messenger with, around the target cell, then of course there's going to be less of that chemical messenger bound to the receptors, and the magnitude of effect will be less. And again, this neuron won't generate these electrical impulses. There'll be a reduction in them, and the person will feel depressed. And that leads into a conversation of, well, why is there not enough serotonin around this neuron, around this target cell. You know, what's causing a reduction in serotonin, the chemical messenger, around the cell? It could be that this neuron just doesn't produce enough serotonin, or it could be this as well. There are little protein pumps located on the plasma membrane of this neuron, and what those protein pumps do, they're called reuptake pumps, by the way, is when serotonin is released from this neuron, right, into the interstitial fluid, what these protein pumps do is they take serotonin and they pump it back into the neuron, and it basically recycles serotonin. Right? You can see that actually happening over here on the left. Serotonin is being released, and what this reuptake pump does, this reuptake protein, is as soon as serotonin is released, the reuptake protein takes serotonin and pumps it back into the neuron, and then it's recycled into these vesicles. So one problem could be that these reuptake pumps are like too active or something. Maybe they're pumping too much serotonin back into the neuron that releases serotonin, and that's not actually, that's not actually causing enough serotonin to be left in the interstitial fluid for long enough. That could be a problem as well. Everything I just went through with you, all are possibilities as to what would cause this neuron here to not generate these electrical impulses, right, called action potentials. It could be any one of those things, or it could be a combination of those things. It's got to be something obviously related to serotonin. Whether it's the serotonin receptors, whether it's the amount of serotonin in the interstitial fluid, it's got to be something that's causing a reduction. Let me say that differently. The reduction in electrical impulses that this neuron is generating has to be something related to serotonin. That's what I'm saying. Now, a drug was created a while back by Eli Lilly, famous drug company in Indiana, that's called Prozac. And Prozac, no matter what, technically, the issue is here, would resolve this problem. Whether it's related to the receptors, whether it's related to serotonin itself, this drug, in theory, should eliminate the problem of this neuron here not generating enough electrical impulses. Serotonin, I mean, if you take this drug, if a person takes this drug, it in theory should resolve this issue. So let's talk about why and how that would be the case. What this drug is that was created by this drug company, it's called a SSRI. That stands for Selective Serotonin Reuptake Inhibitor. Okay, so what the drug does is the person takes the drug, and the drug is a serotonin reuptake inhibitor. So what it does is it goes over to this reuptake protein, or this reuptake pump for serotonin located on the neuron that releases serotonin, and it blocks it. That's what's actually being depicted over here, right? This is Prozac, the drug, the SSRI, binding to the serotonin reuptake pump, right, on the neuron that releases serotonin, and it blocks it, it inhibits it. And that prevents this protein from actually being able to kick serotonin back into the neuron that releases serotonin. So first of all, if you ever hear of the class of drug that's called selective serotonin reuptake inhibitors, SSRIs, that's what's happening here. They're actually binding, and they're binding to neurons that release serotonin. Specifically, they're binding to the reuptake proteins on those neurons and knocking them out, right? It's binding to them and it's inhibiting them, and it's preventing the neuron that releases serotonin from essentially being able to recycle serotonin, to be able to take serotonin and kick serotonin back into itself. Now, what would that do? If someone took an SSRI, right, over here, and it knocked out, blocked their serotonin reuptake pumps on their neurons, then this neuron here that releases serotonin would have a very hard time reuptaking serotonin. And where would the serotonin stay? The serotonin would stay in the interstitial fluid. What would you be doing? You'd be increasing the concentration of serotonin in the interstitial fluid. Now, what do you know about the magnitude of effect? If you increase the concentration of a chemical messenger around a target cell, that will increase the magnitude of effect. Why? Because more chemical messenger will bind to more receptors, and thus the magnitude of effect will be greater, meaning that now this neuron here, this other neuron that we want to generate an action potential, electrical impulse, will generate an electrical impulse, right? Because if you leave more serotonin in the interstitial fluid around this target cell, this neuron here, then more serotonin is more likely to bind to more receptors, and that will then actually cause this electrical impulse to occur. And then the person will feel satisfied and happy, or whatever emotions we're talking about here. They won't feel depressed anymore because now this neuron is generating an electrical impulse again, or it's generating electrical impulses at the frequency that it's supposed to. Now let's talk about why this SSRI, in theory, would resolve any one of those issues, right? Because let's go with the issue. We already addressed this one. We said there's, not enough actual serotonin that's hanging out in the interstitial fluid, right? That could be because the neuron doesn't produce enough serotonin, or the pump is overactive. Well, if you knock out the pump, that's going to resolve this issue. More serotonin will get left in the interstitial fluid. The concentration of the chemical messenger will be higher in the interstitial fluid, and now the chemical messenger serotonin will be able to bind to more receptors, and the problem is resolved. All right, but let's say that wasn't actually the problem, and the problem was more so related due to too few of receptors, right? This neuron here just, let's put a red X through them. It just doesn't have enough receptors. Well, that's fine, because if you still take the SSRI, or the person takes the SSRI, and it knocks out the serotonin reuptake pump, then still, regardless, more serotonin than before is going to get left in the interstitial fluid, right? And if more serotonin is left in the interstitial fluid over a period of time, then more serotonin will still bind to more receptors, even if this person doesn't have enough receptors, right? They have too few receptors, but if you leave serotonin in the interstitial fluid for long enough, it'll still bind to more receptors over time, or it'll increase the frequency by which it binds to the receptors, and that'll still cause this next neuron in line here to actually generate an action potential, and the person will feel satisfied. Same thing would be true if these receptors just didn't have very high affinities for serotonin for some genetic reason, let's say their affinities are low. Well, if the person takes the SSRI, the person's still going to be blocking their ability to reuptake serotonin, and more serotonin will get left in the interstitial fluid for longer, or just more serotonin overall will be in the interstitial fluid because it can't be reuptaken. And even with a relatively low affinity for serotonin, if you leave serotonin in the interstitial fluid for longer, or you have more of it in the interstitial fluid, then more serotonin will have the opportunity to bind to these receptors, even if they have lower affinities. If you have a lot more serotonin in the interstitial fluid, or it stays there for longer, even if the receptors have lower affinities, you can still get them to bind more serotonin and thus cause this next neuron to generate this electrical impulse. So no matter what the theoretical cause of depression would be, right? What is depression, first of all? In theory, it would be this neuron here not generating enough electrical impulses. No matter which one of those possibilities is causing this neuron to not generate enough electrical impulses, the SSRI, in theory, should resolve the issue, no matter what it is. And how the SSRI would accomplish that allows you to take into consideration really all the things that we've been discussing for the last 20 minutes or so. But there's also a problem that could potentially happen from taking the SSRI, especially over long periods of time. So let's talk about that. So if someone takes an SSRI, we can be certain that their reuptake pumps on the neurons that release serotonin will be blocked. Okay? And we can be certain that there will be more serotonin in the interstitial fluid for longer periods of time. All right. So regardless of who you are, if you take an SSRI, that's what's going to happen, right? You're going to end up with more serotonin in the interstitial fluid, and it's going to be there for a longer period of time due to the inability of the neurons to actually take the serotonin back up. Now, here's the potential issue. What this neuron will do that actually binds serotonin is it will recognize that there's all this what seems like extra serotonin in the interstitial fluid. Even if that's the amount of serotonin that you technically want to be there so that these neurons will generate these electrical impulses so that the person will feel better, these neurons really probably won't view it that way, right? They'll view this as an unnatural or an abnormal amount of serotonin within the interstitial fluid. Because after all, I mean, think about it. You are taking a drug, or this person is taking a drug, that's causing excessive quantities, at least compared to what was there naturally, right? It's causing excessive quantities of serotonin to hang out in the interstitial fluid. Right? So oftentimes what will happen, not in everybody, and the degree to which this happens varies, but what the neuron will do is it'll start down-regulating the number of receptors that it has for serotonin. The number of receptors for serotonin within the plasma membrane of this neuron, that binds serotonin and generates these electrical impulses, the number of receptors for serotonin in its plasma membrane will actually decrease, right? Because this is how it's adapting. This is an adaptation. Right? It says, well, there's an excessive amount of serotonin within the interstitial fluid. There's too much serotonin binding to us, so what do? Let's just reduce the number of receptors that we have for serotonin in our plasma membrane, and that's exactly what the neuron oftentimes does. This is really common throughout the entire human body, not just for this. If you expose a cell to an excessive quantity of a chemical messenger, that cell will downregulate the number of receptors that it has for that chemical messenger because, again, it's viewing this, and no matter what you think about it, I mean, the cell is viewing this as an excessive quantity of a given chemical messenger that's not supposed to be there. So to compensate and to adapt, it'll actually downregulate the number of receptors that it has for that chemical messenger, which will do what? It'll reduce the magnitude of effect that that chemical messenger can have on that cell. Because remember the magnitude of effect? If you reduce the number of receptors that a chemical messenger, if you reduce the number of receptors that a cell has for a chemical messenger, it'll reduce the magnitude of effect. And this cell is viewing the magnitude of effect as being excessive because there's all of this serotonin hanging out in the interstitial fluid. So to resolve that, the cell reduces the number of receptors that it has, which drives down the magnitude of effect that the chemical messenger can have. And now the neuron, kind of views it as being back into a state of equilibrium. But for somebody with depression, that's not a state of equilibrium. They just are going to feel depressed again. This can happen months, years, sometimes never. But I mean, this oftentimes can happen to people over the course of time as they take SSRIs or they take any particular drug. What we call this is they generate a tolerance to it. Right? What we really mean by generating a tolerance to the drug is the cells that have receptors for binding that drug, for binding that chemical messenger, they downregulate the number of receptors that they have for that given chemical messenger, for that drug. And then the drug, the chemical messenger, it doesn't have as great of an effect anymore. The magnitude of effect is diminished. So I would, ask you, how do you think you would resolve this problem? You give someone an SSRI for depression. Okay, that blocks their serotonin reuptake pumps, leaves more serotonin in the interstitial fluid, and now more serotonin binds to more serotonin receptors. This neuron generates action potentials. The person feels better. They don't feel depressed anymore. But now this cell, this neuron, views their, sees this excess amount of serotonin as a bad thing, and an excessive quantity of serotonin, and downregulates the number, let's do that in red, downregulates the number of receptors that it has for serotonin. And now the person feels depressed again because, this amount of serotonin in the interstitial fluid, since there's now less receptors for serotonin, still is going to result in going back to previously, what the person had been experiencing. This neuron is going to stop generating as many action potentials, electrical impulses, and they'll feel depressed again. So what do you do to resolve this issue? You give the person greater quantities of SSRIs. And this is what we do with drugs. Right? As the person generates a tolerance to the drug, you give the person more of the drug. Right? Because if you give the person more of the drug, what will happen? Well, if you give the person more SSRIs, then more serotonin reuptake pumps will be blocked, and even more serotonin will hang out in the interstitial fluid. And even though there's now a downregulation of receptors, by taking more of this SSRI, you're now leaving more serotonin within the interstitial fluid, which can bind to more of the, it can bind to the reduced number of receptors that there are, and that'll begin to cause these action potentials, these electrical impulses, to start happening again, and the person will feel good again. But what will happen over time? The cell, the neuron, will continue to view this as an excessive amount of serotonin, and it'll just keep downregulating more and more and more receptors. And then what do you do to compensate? You give the person more and more and more of the drug. This happens a lot in medicine. And it can be rather problematic because you have to take something like this into consideration. Let's say this person's been taking SSRIs for 20 years. Okay? They've gradually had the amount that they're taking increase. Not everybody has to have this, by the way. It varies from person to person. Like, not everybody is getting continual increases in the amount of the drug that they're taking. It doesn't happen to everybody, but it does happen to some people, a lot of people, but certainly not everybody. So anyways, you get increases in the amount of the SSRI that you're taking, the person is taking. Okay, so quantities of the SSRI rises, or sometimes you get prescribed multiple different types of SSRIs. It varies. I mean, these are complex conversations, but generally speaking, the person gradually gets more and more SSRIs to compensate for the fact that they keep downregulating the number of receptors for serotonin that they have. And eventually, the person may get to a point where they just feel like the drug isn't doing anything for them. Or maybe for whatever reason, they just don't feel like they need it anymore. And that's very dangerous, because imagine if after 20 years, the person decided they were done with it. They just weren't going to take SSRIs anymore. Okay? So one day, they just don't take their medication. They're finished with it. Think about what's going to happen now. All of a sudden, since they're not taking this SSRI anymore, all these reuptake pumps are going to go and be active again. And for all we know, this neuron might have actually upregulated a lot of the reuptake pumps that it has as well. That's a whole different conversation. So if the person stops taking this SSRI at a high quantity, now all of a sudden, all these reuptake pumps are super active again. Right? And what are they doing? They're kicking serotonin back into this neuron like crazy. And what about the neuron that actually binds serotonin? It only has like a few receptors left for serotonin. So look at the situation you're getting yourself into here, right? If the person just stops taking this SSRI and all of this serotonin is now being kicked back into the neuron, leaving less, like way less serotonin in the interstitial fluid, coupled with the fact that this person heavily downregulated the number of receptors that they have for serotonin. What's the likeliness now that this neuron here is going to be able to generate action potentials? It's going to be like, close to nothing. Because think about it. They're only going to have a few receptors, and by that I mean, whatever, a huge reduction in receptors for serotonin because of the downregulation of serotonin, right? They're only going to have a few receptors for serotonin. Simultaneously, because they're not taking the SSRI anymore, the vast majority of the serotonin in the interstitial fluid is being kicked back into the neuron that releases it. So they're going to have very little serotonin in their interstitial fluid, very little serotonin in the interstitial fluid, and very few receptors for serotonin. So now this neuron, the likeliness that it's going to be able to generate an action potential if the person doesn't take their SSRIs here is incredibly low, right? If somebody with depression that's been taking SSRIs over the course of 20 years just decides to stop one day entirely, that can be very, very dangerous. Because this neuron, as we said, the likeliness it's going to be able to generate these electrical impulses is like almost nothing. And this neuron generating these electrical impulses is what allows the person to feel happy and content. So if this neuron just, entirely stops, generating any meaningful frequency of action potentials, the person, after stopping this SSRI out of nowhere, could feel severely depressed. And I mean, that's what you oftentimes do see with people that just abruptly decide to stop taking these drugs. If they decide out of nowhere to completely cease taking them, they can develop, incredibly intense depression. Because these neurons that make them feel good, they're just not going to fire because of all this downregulation of these serotonin receptors. Let me say it again, this doesn't happen in everybody. There's huge variance among human beings, but this does happen in some people. And this doesn't just apply to SSRIs, this applies to everything. I was just making a point with SSRIs. They're really the vast majority of drugs that we take, this same sort of thing can happen with upregulation and downregulation of receptors. Now, we didn't talk about upregulation, but you can imagine upregulation would be the opposite, right? In circumstances where there's too little of a chemical messenger in the interstitial fluid, the cell would view that as an insufficient quantity of a chemical messenger in the interstitial fluid, and actually it would upregulate the number of receptors that it has for that chemical messenger. And in theory, that's what should happen if the person were to reduce the amount of SSRI that they were taking, right? There'd be too little serotonin in the interstitial fluid. The cell would recognize that and upregulate the number of receptors that it has for serotonin. And that will happen with people over the course of time. But that's why you would want to slowly reduce how much of the SSRI that you're taking or the person is taking, rather than dramatically cut it all out. Because you'd want to slowly reduce it and slowly let the neurons, upregulate the number of serotonin receptors they have, rather than just cutting it all out at once and just trying to deal with it, right? That would be very, very intense for a lot of people. So 2 more terms for you that are oftentimes related to drugs. They don't have to be, but usually they are. Agonist and antagonist. Okay, so we can have antagonists and agonist drugs. So here is a cell. This cell has an adrenergic receptor on it, an adrenaline receptor, which binds epinephrine. Okay, let's say that you take a drug that mimics epinephrine almost identically. So albuterol would be one of those. Specifically, it goes into the lungs. It's the drug that's in the inhalers that we have, that humans oftentimes use. Albuterol kind of mimics epinephrine. And because of this, what albuterol will do is it'll bind to adrenergic receptors that bind epinephrine. And it actually activates them. Albuterol mimics epinephrine and thus binds to and activates adrenergic receptors. We would refer to albuterol as being an adrenergic agonist. It binds to and activates adrenergic receptors by mimicking epinephrine. Now there are other drugs that are called adrenergic antagonists, and you can probably imagine what those drugs do. You take the drug, and what the drug does is it actually binds to the adrenergic receptor and blocks it, right? It's an antagonist. It binds to the adrenergic receptor and knocks it out. And that actually prevents things like epinephrine from being able to bind to the receptor. In pharmacology, there are a lot of antagonist drugs. Antagonist drugs, you take them, they mimic some chemical messenger. They go along and they bind to the receptor that chemical messenger binds to typically, and knock it out and prevent it from being activated. Anytime that you have an antagonist, it's going to bind to a receptor and prevent it from working. Maybe you've heard of like beta blockers before. Beta blockers are a type of adrenergic antagonist. You take beta blockers, and this would be a cell on the heart, okay? Cardiac muscle fiber. And located on that cardiac muscle fiber are adrenergic receptors. This is like what we just went through. If you take a beta blocker, beta blockers are adrenergic antagonists. So they'll go over to the heart. They'll bind to the adrenergic receptors on the heart, and they're antagonists, so they'll knock them out. They'll bind to them and prevent them from being able to work. Now, what that will do is, as you'll see later on in the semester, the whole explanation as to why, it'll cause heart rate to decrease. Right? And that can be very helpful, because usually what happens is this adrenergic receptor on the heart, right? It usually binds epinephrine, and that causes heart rate to increase. Okay. Well, if you take a beta blocker is an adrenergic antagonist. The beta blocker will go over to the adrenergic receptor that binds epinephrine, and it will block it. So now the adrenergic receptor can't bind epinephrine, and what will happen to the person's heart rate? The person's heart rate will decrease, right? Because they're taking a drug that's an antagonist to the adrenergic receptors on the heart. They can't bind epinephrine anymore, and heart rate will fall. And that can be very helpful for certain people that have like arrhythmias, weird electrical activity within their heart. If you can reduce their heart rate, that can be very helpful for preventing things, for example, from like, maybe you've heard of like AFib before. Some of these drugs can be beneficial in preventing it from occurring, or reducing how severe it is when the person actually is having a bout of it. General rule here: if a drug is an agonist, it binds to a receptor and activates it. If a drug is an antagonist, it binds to a receptor and it blocks it from being able to bind to its usual chemical messenger. This brings the discussion of chemical messengers in this course to a close. And what we're going to do next is we're going to use a lot of this information that we just discussed in talking about the endocrine system, which is next.